Guys, it's time for some more board review questions, so let's just get started. A 54-year-old man presents to the office for routine follow-up. He reports a mild headache, which is relieved by Tylenol. He has an EKG, which is shown here, and it looks like he's got some ST segment depressions here. She's got some J point elevation here. I wouldn't really call that a ST elevation, but some more ST depressions in the lateral leads. So maybe I am getting a little bit more suspicious of this. Let's look for any T wave inversions. I don't see any other. So AVL, V5, V6. So all those lateral leads over there. So which of the following is the most appropriate next step in management? Refer to the ED, evaluate for secondary causes of hypertension, start clonidine, obtain CT head without contrast, and resume antihypertensive regimen. So this is, if we think he's having like an MI, then that would be that. Wouldn't really cause a headache necessarily, but you never know. Secondary causes of hypertension. So one good thing to look at is, does he have signs of LVH? And here, there's quite a few criteria that you can use to look for LVH. So you add the tallest R segment in V5 and V6 to the most negative S segment in V1 or V2, and if that's greater than 35, that's a sign of LVH. And with LVH, you can get these repolarization abnormalities. You can also look for a lead AVL if it's greater than 11 millimeters. That's also a sign of LVH. And also, there's one criteria where you look at V3 and AVL, and then depending on if it's male or female, you also meet the criteria for LVH. So let's see. He reports a mild headache, no complaints, has a history of hypertension for which he's on hydrochlorothiazide, losartan, and nifedipine. He reports non-adherence with his medication over the past week while he was on vacation. His blood pressure is 210/120. Physical exam is normal. Lab tests were performed 3 days prior and are within normal limits. So it's pretty high. So we're trying to figure out, is this hypertensive emergency, which is blood pressure of greater than 180/120 with signs of end organ damage? Or is this hypertensive urgency or asymptomatic severe hypertension? Now, a headache, you could start to think of, are they having some kind of cerebral edema or something like that, which would be hypertensive emergency. But in this case, it's only a mild headache. And then we've got all these repolarization abnormalities here, which we're not really getting any signs that he's having an acute MI. So I think he actually could just resume his previous antihypertensive regimen. So yeah, this was a difficult question for people because there's a lot of ST changes here. And so a lot of people could get really concerned about that and think that they're having hypertensive emergency due to having acute coronary syndrome. But they're not giving us anything in the question stem about acute coronary syndrome. And all of these changes that we're seeing are secondary to his LVH, his left ventricular hypertrophy, and has these repolarization abnormalities. Secondary causes of hypertension, well, he hasn't been on that drug regimen, the 3 antihypertensives, so we don't know if he has secondary hypertension. Usually after they've been maxed out on 3 blood pressure medications, and then it's still resistant hypertension at that point, then you'd be looking more at secondary causes. But in this case, we should just restart his antihypertensives. Clonidine, not a great antihypertensive, has a lot of rebound hypertension, especially in somebody who has a history of non-adherence. If they stop taking it, they're going to have rebound hypertension. Also has a side effect of depression, which is not a really great side effect to have. CT head without contrast, if we're concerned for some kind of brain bleed, then that would make sense. But mild headache, we're not concerned about that here. All right, next question. A 73-year-old man presents to his physician's office for evaluation of a facial rash. I'm looking at it here. It's kind of centralized on the nose. So immediately I'm starting to think of like rosacea potentially, although there's like a pustule here. So there's papulopustuous, I don't know what the exact term is, papulopustular rosacea, more of a derm thing, but extremities are without edema. Which of the following is the most likely diagnosis? So it's not seborrheic dermatitis. Seborrheic dermatitis, you get that crusty yellow, kind of oily, crusty feeling. Cutaneous lupus, very unlikely in a male. Also, I believe it's very uncommon for it to just to be isolated on the nose. Keratosis pilaris, I can't totally remember what that is, but I believe that's more of like follicles, involving the follicles. Acne vulgaris, probably less likely in a 73-year-old man. Most likely diagnosis is going to be rosacea. So he reports the rash involved most of his face when it started 2 years ago. 1 year ago, he was seen by another physician who prescribed topical triamcinolone 0.1%, which initially improved his symptoms. Now the skin lesions have returned and are worse, prompting today's visit. His skin does not itch. He recalls having acne as a teenager, but it is not as severe as he is currently experiencing. His past surgical history... Sorry, guys, I just realized that I did not have the correct resolution, so my recording was in the wrong resolution. His past surgical history has a cholecystectomy, no other medical history, family history unknown, volunteers for 3 different organizations. He's a pretty healthy guy, blah, blah, blah. Everything seems pretty normal. So in this case, I'm going to just go with rosacea, papillopustulous rosacea. And we can see 66% of people got it right. So let's take a look at these other conditions. So acne vulgaris is going to be in young adulthood. Keratosis pilaris may be difficult to distinguish from rosacea, but is more common on the upper arms, upper legs, and trunk. It is less common on the face. It is a common diagnosis in teenagers. Okay, and then cutaneous lupus is discoid lupus. So just pulling up my Anki real quick, if we take a look at rosacea, then we can see there's papillopustular rosacea, which is probably what this guy has. And that's going to probably be this inflammatory rosacea here. There's multiple different types of rosacea. And then cutaneous lupus, there's actually a couple things. There's one called subacute cutaneous lupus erythematosus, which actually spares the central face. So that's kind of what I was alluding to earlier. So you have acute cutaneous lupus, which is the classic butterfly rash, and then the subacute cutaneous lupus erythematosus, which is a photosensitive rash that usually spares the face. Next question. A 65-year-old woman has been admitted to the ICU for the past week following a hip replacement surgery. She has a consolidation in the right lower lobe. There's gram-positive cocci in clusters that are resistant to cefoxitin. White count is elevated at 15,000. Creatinine is 1 and her sodium is 140. Which of the following is the most appropriate treatment? So it's got to be vancomycin. Before even reading all this, it's got resistance to beta-lactams. So you can't use any of these beta-lactams, and we're not going to use, we don't typically use ciprofloxacin. So for a gram-positive thing, it's really, that's more for coverage for Pseudomonas and gram-negatives, for example. The patient states that she started to feel generalized fatigue, shortness of breath, and discomfort in her chest. Blah, blah, blah. Everything else looks pretty normal. She has osteoarthritis and osteoporosis. Medications include ibuprofen. They have a lot of fluff in here that really is not necessary. So the fact that she's been admitted to the ICU for the past week means that we can treat this as hospital-acquired pneumonia. And so we would initially just start off these patients on vancomycin and cefepime. And then the fact that we know that the cultures are going gram-positive culture cocci now, we can narrow it to just vancomycin. So vancomycin, you can see 81% of people got that right. Next question. A 34-year-old woman presents to her gynecologist for evaluation of infertility. FSH and estradiol levels on day 3 of her menstrual cycle are normal, and her AMH level is within the normal range. This is going to be a difficult question for me because I don't deal with reproductive hormones or evaluation of fertility very often, but it is something we need to be aware about. So which of the following is the most likely finding in a patient with this condition? Fallopian tube obstruction, bicornuate uterus, prolactinoma, uterine fibroids, and multiple ovarian cysts. So the fact that her FSH and estradiol levels are normal makes me think less of prolactinoma. If she had a prolactinoma, we would probably see a suppressed FSH and estradiol is what I'm thinking. Bicornuate uterus can lead to infertility. It's just one of those embryologic things where it doesn't form quite properly. But we'll have to see. Fallopian tube obstruction. I'm not really familiar with a lot of these. Uterine fibroids. So this is going to be a very common cause of infertility. So she and her husband have been trying to conceive using timed intercourse for the past 16 months without success. So because she's less than age 35, we term infertility as being after 12 months of trying to conceive with no success. If she's greater than 35 years old, then the cutoff is 6 months. So her partner has a normal semen analysis. Her menstrual cycles are normal. Menses began at 14, and she had one full-term pregnancy at age 25. So she's able to get pregnant. She has elevated cholesterol levels and a history of chronic migraines. She does not smoke and drinks alcohol occasionally. BMI is 26, mildly overweight. Breast exam is without masses or nipple discharge. She has a normal non-tender uterus with non-palpable adnexa. Gosh, so this is hard. So she is mildly overweight. She does have some signs of metabolic syndrome. So, one thing I'm thinking is polycystic ovarian syndrome, because I'm not getting anything about fibroids here. Fibroids, usually they would tell us there was something, some kind of pain or something going on, or bleeding, abnormal bleeding. But here, I think the fact that she's overweight, she's got some metabolic syndrome, rest of her workup is pretty normal. Let's just go with PCOS, polycystic ovarian syndrome. And we are wrong. So the correct answer is fallopian tube obstruction. I haven't really heard of that very much. So tubal obstruction and anomalies account for 30% of cases of female infertility. Because this woman has findings indicating normal ovulation and ovarian reserve, regular menstrual cycles, hormones, and physical exam, it is important to rule out tubal anomalies with a hysterosalpingogram as the cause of infertility. Okay, and the most common cause of tubal obstruction is pelvic inflammatory disease. Other people develop it without any known risk factors. All right, so interesting. I did not know that one, and this is a good learning point for me. So bicornuate uterus, looks like they have pelvic pain, abnormal bleeding. Uterine fibroids also has uterine bleeding. Prolactinoma will cause galactorrhea and also some other symptoms. And then PCOS would usually show... See, while this patient has some signs of metabolic syndrome, such as elevated BMI and elevated cholesterol, she has regular menstrual cycles, which indicates ovulatory cycles. All right, let's do the next question. A 25-year-old woman who was diagnosed with Graves' disease in another city presents to her new physician for follow-up care. A thyroid ultrasound confirms a hypoechoic solid nodule measuring 2.5 centimeters in diameter with no microcalcifications. Which of the following is the most appropriate next step in management? Perform a fine needle aspiration biopsy of the nodule, refer for immediate thyroidectomy, measure the thyrotropin receptor antibody level, resume methimazole and repeat the ultrasound in 6 months, and treat with radioactive iodine. This one's actually a little tough for me too, so we'll see. Vital signs are normal. Her skin is slightly warm and smooth. No erythema or eyelid edema. Her thyroid is twice normal in size, and there's a slight tremor of her outstretched fingertips. Lab results include TSH 0.2, so still suppressed. So still low, so she still is a little hyperthyroid, and her free T4 is on the upper range of normal. So methimazole is held for 4 days, and iodine 123 uptake and scan shows a homogeneously enlarged thyroid with a hypoechoic area in the right lobe. Homogeneously enlarged. So that does sound like Graves' disease. It's diffuse. But she does have this additional nodule here. 2.5 centimeters is fairly large. I'm a little bit unsure here. The thyrotropin receptor antibody level, she already has proven Graves' disease, so I don't see that being super helpful. Resume methimazole and repeat the ultrasound in 6 months would be helpful if potentially some of these nodules are related to Graves' disease and might get better, but that doesn't sound super convincing to me. I think maybe this nodule is just incidentally also noted there. Radioactive iodine also seems a little bit aggressive to me. And then immediate thyroidectomy also seems a little aggressive. I'm not 100% sure. Like radioactive iodine, thyroidectomy, both of those are going to cause her to be hypothyroid immediately, and they just seem a little bit more invasive. I'm not sure that this nodule is going to go away on its own just by treating the hyperthyroidism. So maybe let's go for a fine needle biopsy, because I do have some Anki cards that I believe say that there's kind of a low threshold to get these. Although hypoechoic solid nodule is pretty normal sounding. It doesn't have any It doesn't have any calcifications or any other criteria that makes it a little bit more concerning. Although 2.5 centimeters is fairly large. So, but I feel like B and E are pretty much the same answer. And then D is saying that treating the hyperthyroidism will improve the nodules. So I'm not sure about this one. 73% got it right. So let's see. Performing a fine needle aspiration biopsy of the nodule to exclude malignancy is the most appropriate next step. FNA is indicated for any solid hypoechoic thyroid nodule greater than 1.5 centimeters in diameter. For smaller nodules, FNA biopsy is indicated if there's any features that are suspicious for malignancy. Treating with radioactive iodine is often part of the management of hyperthyroidism. However, biopsy of the nodule is indicated first. Thyroidectomy is an option in a patient with Graves' disease who has a potentially malignant thyroid nodule. Resuming methimazole is not the appropriate next action, as this would delay the FNA biopsy. And referring for immediate thyroidectomy would not be indicated without establishing a diagnosis of thyroid cancer. All right, so those are the 5 questions for the day. Hope you guys enjoyed. I went through them pretty quickly, so let me know down in the comments if you have any questions. Thanks again for watching. I'll see you in the next one, and peace.